coming. I'll show you 4 slides on the work that we have done here, and I think it complements the work that was just shown. In cytology, oftentimes the challenge is not enough cells. There's just a paucicellular sample, and there's not enough cells present. And one area where this happens a lot is in fine needle aspiration of the pancreas. Also, oftentimes there'll be a concern that there is carcinoma, but the cells show some atypia, not enough to make a definitive diagnosis. To be able to provide more information in this specific setting, we considered the following. It is usually the practice in cytology to centrifuge the sample at some point, pellet the cells either into a cell block or onto these slides. That leaves you with a supernatant, a cell-free supernatant that's usually discarded. We hypothesized that there could be DNA in that cell-free supernatant, DNA likely from the same cells that one is trying to make a diagnosis. So what we did was we asked, is there free DNA in the cytocentrifugation supernatant fluid, and could we detect mutations in this fluid? If this is so, then you have a potentially complementary sample that doesn't take away from your cells, that allows you to be able to look for that. So what we did was, first we did a kind of small training set. We took a series of known adenocarcinomas in cytology, so there wasn't any doubt, and also a series of pancreatitis, negative specimens. And these were all patients with confirmed clinical status. And we looked at the cellularity. You can see sometimes the cellularity is low, and oftentimes it's a hypocellular cytology sample. We microdissected the cells, so that will presumably show the mutational profile in the cell. Then we took the cell-free supernatant fluid that has no cells in it. We extracted DNA and did the mutational analysis on those two. We looked for 17 mutations associated with pancreatic cancer. You can see here are that have KRAS in the cells, KRAS in the super. Well, you can see the positive cases, even though there are no cells, there is mutated DNA in the supernatant. If you needed to, you might want to look at that. Now, here's the mutational profiles between the two. You can see many of them are equivalent. We got the same mutations in the cells as in the supernatant. In some cases, though, the supernatant had either more mutations or the DNA was mutated with more mutated cells with that same mutation. Like, for example, here, there's a mutation on chromosome 22. It's present in a low proportion, a subset of the cells microdissected off. But the supernatant has more mutated DNA. So it's kind of counterintuitive initially. Why should there be more mutated DNA? But then if you think about it, probably the cytocentrifugation supernatant is enriched with the DNA from the most actively turning over cells. And those are the very things that one is concerned about identifying. Anyways, in this training set, none of the pancreatitis cases had any mutations in either, but there was equivalency or more mutations in the cytocentrifugation supernatant as in the cells. We then looked at 14 cyst wall biopsies. Now, many GI docs are doing a procedure for pancreatic cysts where they aspirate the cyst and then they puncture the wall to try to get at the lining of the cells. These are difficult specimens. They can be hypocellular, and oftentimes they won't be able to make a diagnosis of cancer. Well, you can see that, again, there were a number of cases where there weren't enough cells to be able to do a mutational analysis from the cells themselves. But when you looked at the supernatant, there were multiple mutations. There was, in every instance, the supernatant fluid, free of cells, just free DNA, contained either the same number of mutations or more mutations than that present in the microdissected cell. There were a number of hypocellular samples that could not be effectively diagnosed by cytology. They were considered inadequate. They had enough DNA, and in some cases they had mutations. So all of this leads to the conclusions. The conclusions are these. The supernatant fluid that is gathered during the normal course of cytology preparation contains free DNA that likely represents the most actively growing cells that are in where that needle aspiration occurred. There is DNA, it is amplifiable, it can show more mutations, it can show more mutated cells for a particular mutation than the cells. The cases that were positive were better characterized by the supernatant than by the microdissected cells. You might wonder, how could that, why would the supernatant without cells be better than the actual cells? Because oftentimes the aspiration will include inflammatory cells, stromal cells, benign cells. So there's a mixture that one is dealing with. But the supernatant is enriched with the most actively growing cells. Cytocentrifugation, you might want to hold on to it. It could provide a source, an excellent non-competitive specimen for molecular analysis. And in our studies to this point, the sensitivity and specificity is excellent for this type of specimen. Hence, I think, supporting further work to continue along this line. Thank you very much.
So in the first group here, these were not cystic lesions, right?
No, these are solid lesions, the first group. These are cysts, these are solid. Solid adenocarcinoma, not a cytology problem. But they should. It was surprising. We thought the cytocentrifugation supernatant wouldn't be useful. And here are all the mutations. These tumors are emitting DNA all into their environment. And so this is possibly a complementary way to look for mutations. So make a diagnosis.
How did you get this idea? Has anybody done this before?
Question was, how does he get this idea?
Not a whole lot. No, there are some comments about the centrifugation, the supernatant in pancreatic juice. People sometimes look for pancreatic cancer. They've done that looking at secretin stimulation, collecting the pancreatic juice. So there is literature on that. So that was part of why we asked, gee, if it can be in the pancreatic juice, why not in the cytocentrifugation supernatant? Also, people do look at circulating blood for mutations. What are they doing there except what is being done here with a specimen that's closer, more within your control?